Great pleasure to be here. Saying that, there are few topics that are less sexy, yet more important than data. And when we're talking about quality measures, what we're really talking about is having meaningful data. And the purpose of this talk is to provide an introduction for the session and talk about the sort of metrics that are important when we're talking about quality in hernia surgery and some of the significant challenges that exist when trying to collect that data. And clearly, knowing where our successes and failures lie is hugely influential, as is knowing how our local hospital compares to the wider surgical community. But more than that, knowing our outcomes allows us to give our patients informed advice and in turn let them make truly informed decisions about the care they receive. And when someone asks about the complications from hernia surgery, they don't want to hear about the complications from a randomized trial. They want to know about the complications in my hands, in your hands, and perhaps how that compares to the provider down the road. And unless we collect our outcome data, then at best we're guesstimating those figures. And a good example comes with something as simple as recurrence following primary inguinal hernia repair. And I always used to tell patients that the risk of recurrence was about 1% because I thought from the best evidence that that was the figure. And if we look at the best evidence, or what I thought was the best evidence, large multi-center randomized trials, and on average these trials recruit in the region of 600 patients, usually across about 5 centers, the risk of recurrence is almost uniformly reported at less than 1%. But if we look at countries that are a little bit ahead of the game and have national registers of hernia surgery, and this is an example from the Swedish Hernia Registry, but very similar figures come out of the Danish Hernia Registry and the German database, what we see is a much larger number of patients, a much larger number of centers, and almost a 4-fold higher risk of recurrence. And it's easy to jump to conclusions about why this discrepancy exists. You say, well, randomized trials are performed in expert centers that have high volume, they're specialists, and they just do the operation better. But the reality is that randomized trials have very select inclusion criteria and limited follow-up, and they only pick up a very small snapshot of all hernia patients. Whereas a register picks up a much greater picture of all the hernia repairs that are going on. And simply to jump to a volume outcome relationship causation, although there may be an effect, is not supported necessarily by the data. When I started training as a surgeon, I wanted to be a good surgeon, and I still want to be a good surgeon. But my interests shifted into not only what makes me good, but what makes us all good. And when you start out initially, you have to learn the technical skills of how to do the operations, and that's challenge enough. And then you have to pick the right patients to do the operation on. And then it's picking the right operation for the right patient and actually tailoring your care towards the patient. And then in the midst of all this comes this new context of what it means to be good. And undoubtedly, medicine and surgery is in the deepest crisis it's been in for a century. Something that you don't normally think of as a surgeon when you're trying to do good for patients, and that's cost. And there isn't a country in the world who isn't questioning whether we can afford what we do. And that starts to introduce the concept of value, where value is the quality of what we do divided by the cost. And the sort of measures of quality in hernia surgery might be recurrence, or importantly, chronic pain, wound complications, and the sort of measures of costs, number of hospital visits, length of stay, the resources that we use, the type of mesh fixation, and the technique, and very importantly, readmissions. And readmissions has a big star because the cost of readmissions is so significant that it blows all of these other cost measures out of the water. And whilst the quality and cost metrics are separate, it's important that both these sets of metrics are measured in order to be able to give us a value measurement. And the principle being that if the quality goes up but the cost remains the same, the value of care that we provide goes up. Similarly, if the quality remains the same but the cost goes down, again the value goes up. Clearly, if the quality goes up and the cost comes down, then we get the biggest increase in value. The danger with looking at value alone without looking at quality and cost metrics independently is the stack 'em high, sell 'em cheap approach, where the quality goes down, but the cost goes down to a greater proportion. And what we see is a relative increase in value, but this is an undesirable effect. And none of this takes into account the overall patient experience. And when we start to bring that in, the overall experience right through from pre-op through to their recovery and the indirect costs, not only are we talking about value, but we also start talking about appropriateness of surgery. And by measuring these outcomes and identifying the positive deviants, those that are offering the best value, the most appropriate care for the same cohort of patients, we're able to identify where the opportunities exist to improve the whole system. And that's the principle behind measuring these sorts of metrics. And we're behind the game. There's the Danish hernia database, which is a national register, the Swedish hernia database, the Germans have a registry. The EuroHS is an online European Hernia Society funded platform, which is available to surgeons in the UK, and I'll talk a little bit more about that later. And the American Hernia Society have their quality collaborative, and they're trying to identify these sorts of metrics and this kind of data. So why don't we do it if it's clearly something that's going to help? And the reason is that arriving at meaningful, fair, and intelligible data is incredibly complex. And this is a cartoon that we used for the Bulletin of the Royal College of Surgeons of England when we published an edition on outcomes. And it sort of shows the polarity of views that come when we talk about surgeon-level outcome data. And where do those problems start? Well, they actually start with what do we measure? What outcomes do we measure? And we've discussed some of the outcomes, but let's just pick one: recurrence. What do we mean by recurrence? Are we talking about symptomatic recurrence? Are we talking about clinical recurrence? Are we talking about radiological recurrence? And what sort of level of recurrence is acceptable? If someone's having a complex incisional hernia repair, where the abdominal wall's being completely reconstructed, then someone who ends up with a small epigastric recurrence, the operation's still been a success, but they have a recurrence. And on the back of that, should we and how do we risk adjust for more complex patients and hernias? What we don't want to do is encourage an environment of unnecessary conservatism and risk-averse behavior. And how do we measure it? How do we accurately and reliably collect this data? And how do we validate it? What processes are in place to ensure the accuracy of the data? When do the true effects of an operation become apparent? We know with hernia surgery that recurrence can occur 15 or 20 years after the initial procedure. And this is a particular problem for groin hernia surgery, where we're trying to save costs. We don't routinely follow up patients. So how do you collect this data? And if someone does have a problem, often they present to a different provider. And then the practicality of it. How do we do this without massively increasing the surgeon's workload, where they're already filling out an operation note, already writing in the patient notes? And then how does this data get disseminated at a local level, at a national level, and importantly, to the public? And one way of doing it is using hospital episode statistics, and certainly there's a lot of advantages to using HES data. This is what you tell the world that you do. This is how the hospital gets paid. You're able to risk adjust partly for more complex patients because comorbidities are coded with HES data. It's consistent across all NHS providers. And this is the basis for the SWORD database and the Getting It Right First Time project. And they've done fantastic work in trying to make HES data intelligible, to make it into a usable format. But, and there's a big but, the quality of the data is only as good as what's inputted. And we're bad as surgeons at writing the right operation in the operation notes. Anytime the diagnosis is written and a question mark is put in front of it, the coders can't code for it. If the comorbidities aren't written in the notes, then the coders can't code the comorbidities. And HES data only picks up NHS patients, no matter where they're operated on, but it'll only pick up NHS patients. So someone who's a busy colorectal surgeon who does 150 hernias in the private sector, but only does 1 in the NHS because they don't have time within their NHS practice, that won't be picked up on HES. And then we move on to the codes that are actually used. And this is the codes for, this is the ICD-10, the disease codes for inguinal hernia, essentially primary or recurrent, bilateral or unilateral, with obstruction, with gangrene, or without. So according to HES, this primary unilateral inguinal hernia is the same as this. And when we move on to incisional hernias, it gets worse, because the codes are very, very similar. But this small port site hernia, according to HES, is the same as this abdominal catastrophe. And then we move on to the operation codes. So this is for incisional hernia. Essentially, it's repair of primary or recurrent hernia using either sutures, synthetic mesh, or biological material. So it doesn't document at all whether it's an onlay repair, a sublay repair, if it's a laparoscopic repair, whether the defect's simply been patched, or whether there's been primary closure of the defect, whether a component separation has taken place, either open or endoscopically. And it's a little bit like saying, Professor Sheen drives a car, and I drive a car. They're both cars, but they're clearly not equal. So we move on to other ways that we can measure outcomes, and I talked a little bit about the EuroHS platform. This is open and free to use for all UK surgeons. It's an online portal. It will give you surgeon level, hospital level, national level, and European level data. This is an example of the sort of CRF forms that they use, but these are all filled out online. I've just used this as an example. And this has a lot more detail about the patient and about the type of hernia and about the type of repair that's being performed. None of these measures take into account the overall patient experience that I talked about. And that's why there's a big drive to use PROMS. And interestingly, PROMS for hernia consists of 2 measures, the EQ5D index and the EQ-VAS. Now, it's the only PROM, the PROM that's used in inguinal hernia surgery, that doesn't use a disease-specific measure. And if we look at this in more detail, we look at the EQ5D index. It's a measure of chronic health, mobility, self-care, anxiety, depression. These aren't problems that someone presenting with a primary inguinal hernia has. So you have to question the validity of the data that comes through the current system of PROMs. Clearly, PROMs are a good idea, but why these metrics have been chosen to be measured, I'm not sure. It's without question that the task of the next generation, my generation of surgeons, will be making systems work. And in every field, medicine has exploded with knowledge, and that includes hernia surgery. And with it, it's brought complexity, it's brought specialization, and no matter how individualistic we wish to be, complexity requires group success. And in order to do that, we need to know our outcomes. We need to know where our successes and failures lie, and intelligent data is the key. And amongst those metrics utilized, like it or not, cost is a very important measure. HES data is out there, it's readily available. We need to make sure it's accurate. We need to try and address some of the coding issues to make it easier to interpret and easier to differentiate more complex cases. In the interim, until that happens, the EuroHS platform is there and available, and I suggest at a local level that everyone uses it in addition. And we all need to be using the same measurement tools, otherwise, once again, the data becomes meaningless. Thank you.
So, if I usually make a mess of my talk, there's no excuse. But I'm going to start with an excuse. It's not my talk. It's important for us to remember that groin hernia repair is the most common operation we do in general surgery. In the United Kingdom, there are about 100,000 repairs annually. That obviously includes incisional hernia, inguinal hernia, and all forms of hernia. That is about twice as much as the next most common operation we do, and that's cholecystectomy. So we really need to get it right. Poor outcomes means we lose the operation. This is Paul's declaration of his only funding and competing interest. So he started out a hernia outcome campaigns with these individuals. Some of you will know Stephen Atwood, Paul himself. These are a mixture of private and NHS surgeons who are interested in laparoscopic and open hernia repair. So they're quite a good mix to actually look at this thing. So this is how they got their information. So in 2012-13 in England, there were 55,000 hernia repaired by 2,500 surgeons. So that comes as an average of 20 hernia repairs. This is inguinal hernia repair per surgeon, and that should be the median number of repairs per surgeon is 10. I'm sure that comes as a bit of a surprise to most people in the audience. I knew it was low, but I thought it was in the region of 30 rather than 10/20. Why does volume matter? Well, we know from many studies that volume matters, certainly in esophagogastric surgery, pancreatic surgery, liver surgery, colorectal surgery. But do we have any evidence in hernia repair that it matters? In inguinal hernia repair in particular? And the answer is yes. A lot of you will be aware of the large American randomized clinical trial looking at open mesh repair versus totally extraperitoneal repair. And the learning curve for totally extraperitoneal hernia repair was estimated at 250 cases. Interestingly, there was no evidence of a learning curve for open mesh repair. So laparoscopic repair makes it a much more complex operation and has a long learning curve. These are just other, you will all know about Berkmeyer and his New England Journal of Medicine papers looking at volume and outcome in the various areas. This is same in orthopedics, total hip replacement. And this is the one that Paul quotes for. But the American one is a better sort of prospective randomized clinical trial, 2,000 patients randomized, 1,000 in either arm, and shown that the volume, that you needed a learning curve of 250 for a totally extraperitoneal repair. And that's, some surgeons don't do 250 repairs in their lifetime. So I'm going to start at the bottom here. So 1 in 5 surgeons perform 1 repair in the United Kingdom. And that's because people are obviously very specialized in other areas and they don't consider hernia repair as an important part of their practice, and they seem to be very comfortable at doing 1 repair. Now the question is that appropriate? So 10% less than 6 and 10% less than 20. Oops. So most hernia repairs are performed by low volume surgeons and doing less than 25 repairs. This is in England per year. I'm going to start at the bottom again. I know Paul would have started at the top, but I think the bottom is more interesting. London is interesting in that surgeons performing between 1 and 4 a year, 43% of London surgeons perform between 1 and 4 a year. And then there's variability in the other regions. Does it matter? And I think that's a reasonable statement. So the issues that you have, it's clearly there's a huge training issue. How can you train a surgeon if you do one hernia repair, or indeed a quarter of all surgeons do 1 to 4 hernia repairs in England? It's not possible to train somebody in hernia repair, in open, and definitely not in laparoscopic, that's for sure. The issues, I guess the issue that has dominated inguinal hernia repair over the last 15 years or so has been chronic pain. Now, severe chronic pain is a real problem, and that somewhere between 3 to 6% of our patients will complain of severe chronic pain. Now, can we reduce that by increasing surgical volume? And the answer is probably yes, but we've absolutely no data, certainly in the United Kingdom, to support that. Recurrence, you already saw that the Swedish database of almost 150,000 patients has showed a recurrence rate of just over 4%. What you must remember about recurrence, these are people that come back for a second operation, but the number of people that have a recurrent hernia is probably double that. And we certainly know that from the old days of sutured repair, where national studies show that about 1 to 10 people came back for a reoperation, but prospective data show that about 1 in 5 recurred. And so there's no reason to believe that that has changed, that if you're nationally reporting a 4% recurrence, the probability is that it's closer to 10%. And that's a bit disappointing for mesh repair. So I guess this slide is asking, should we have specialists in hernia surgery? Should we have hernia and soft tissue surgeons? We have upper GI surgeons, we have colorectal surgeons, breast and endocrine. Should we have people trained in hernia and hernia and soft tissue surgery? And as we know, a hernia repair can be a 5-minute epigastric hernia, putting a few stitches, the most complex operation you can think of in somebody who has a complete loss of the main of the abdominal wall and multiple fistulas and multiple previous attempts at repair. And I, who do all sorts of other kind of surgery, can tell you that that's the kind of surgery I just don't like, but unfortunately it's the kind of surgery I end up doing every week. It's harrowing and difficult, and the outcomes are poor. Once hernia surgery goes wrong, it's very hard to get it right. And I always say to these people that come into me, I say that there's still a high risk that I won't have helped you by a further operation. And the reason I know that is not all of them do well. So these are just questions he's asking himself regarding, you know, if you've done 1,000 and you do 10, is that okay? There's a lot of questions we could ask in terms of... So what are the next steps? Well, he's trying to bring it onto a political level, and our administrators and our politicians are not hugely interested in hernia repair. And when I started off, it was relatively easy to get funding to do relatively good studies in hernia repair. But as I can tell you now, it's difficult, and being on various committees like the Medical Research Council and various other, these people by and large are just not interested in funding trials in the most common operation we do in general surgery. Now, I wish Paul all the best in his roundtable thing, and I hope it works, but don't be surprised if it doesn't. Thank you very much.
I think it's a fashion to make a selfie of yourself, like this one at the funeral of Mandela, our Prime Minister, your Prime Minister, and the President. They had lots of fun, and I don't think she had so much fun about this, but today I'm going to do a selfie on what I think, and you may have me excused, but this is going to be non-evidence-based thoughts, although I'm going to rely on some data, of course, but you can argue with me, and I would like to be a little provocative, and I'm maybe excused because English is not my native tongue, so bear over with me. I'm going to talk and focus on our database, which I have been part of almost 20 years. God bless me. It's been running a long time, large-scale nationwide data, long-term quality monitoring of this procedure, provision of low-level evidence, according to the rank of evidence, you know, but with some kind of external validity. And I'll try to give you some clinical examples which has at least puzzled me, and maybe also some of you, if you have read some of the papers. My conclusion of what I'm going to say today is that I'll try to give some thoughts of what not to do and what to do if you want to do this kind of quality monitoring database. Everyone talks about it, but I think a lot of guys do not really realize what it's all about. It is to keep things very simple. Do only pose 1 or 2 hypotheses. Keep variables that you register very, very low on, otherwise you will not have the data in. Surgeons are busy and they are sometimes not that collaborate. You have to have some kind of validation system, and you have to have, this is very crucial, a good follow-up system, and you have to have reliable systems for handling the data and to access the data, and you have to have a high coverage, about 85–90%, and then you have, well, you have to do a lot of free work, non-paid work, and you have to be very enthusiastic. And if you do not do this, you'll have garbage in and you'll have garbage out, and you can use it for nothing, sorry to say it. So, over the years, there have been now more or less 11 registers, started with Sweden and then Denmark, and then all the other ones, and they're not national, but some of them are actually doing quite well, and the publications over the years from this special little field of surgery, although we do it a lot, but it's not sexy surgery, we do it a lot, but there's been quite a lot of peer-reviewed publications over the years. And now I would like to focus a little on the Danish hernia database, which actually started 20 years ago with the groin hernia. I'm not going to talk much about the groin hernia, but I'll do that in the next session. I'll more focus on this ventral hernia thing. But the principle is the same, and the principle can be used as a model in every kind of it's pancreas, liver, or whatever you're going to do. You need to have a very enthusiastic steering group, central persons, 2, 3, or 4, not 5, 6, or 7. 2 or 3 persons who are going to take up the initiative to do what should be done. And then you need, the most crucial thing is communication. You need to talk to all the surgeons dedicated within the surgical field in your country. And you can actually do this in Ireland as we can do it in Denmark, but you need to have a high communication level. And practically we did that over all the years for 2 annual meetings and lots of letters, lots of telephone calls and so on. And what it's all about is that you have a data-driven discussion. Being academic surgeons, working surgeons, but we have to rely on data-driven discussions, we have to collaborate, and we have to put up relevant hypotheses, and we have to have good research questions, and then we can make the database to fit into all this. This is what it's about. And here is actually me standing there. But when I've done this surgical procedure, I go outside the OR. I don't go in the OR, but outside, and I put immediately in the data. It takes me about 2 minutes to put it in the internet. In the old days, we did it in a paper form, and it worked very well. We had a lot of problems when we went to the internet, a lot of problems, but it's okay now. But it was no fun, I tell you. But now it's much easier. And this is basically how it looks like. This is just a screen dump. So you tack, and then you have reported every detail which is important during the operation. So we have an exact picture of what went on, what did we implant into the human body cavity, or whatever we did. So in Denmark, it's mandatory, actually, by law to do this quality assessment registration for every kind of surgical procedure, and also for hernia. And the leading doctor of the hospital will get smacked if we do not follow these obligations. Until now, the registrations has been anonymous, but now we are benchmarking surgeons against one another. We started 3 months ago, and it will be a big fuss about this, but we agreed about it in the Hernia Society group, and we'll see how that will go. But it's delicate, because maybe we will have the registration rate fall down, but we'll see to that. And it has a big political attention, this quality marking, actually. So this is how it goes. The patient gets into the operation, he has his repair, the surgeons go out and register immediately after, 2 minutes it takes, and then the hospital will not get any money, and they will not get reimbursed if they don't bring in the operation code to the authority, to the Danish National Patient Register. So this is very smart, because then we can combine, this is the truth. This is really the truth. This is money. So we can combine what we have registered here with this, and if we have a missing registration, we go to the surgeon or the hospital, and the surgeon will have the file, and please after registrate. The after registration is not that often, but we have this very good validation, I think, and it's very, very crucial to have that. And of course it costs money, but this is nothing. It's for half a secretary and peanuts, nothing actually. Now, we have, and I understand that you in UK and some other places also have a unique social security number, but we actually, in Denmark, we actually use it, and it's not forbidden to use it. So we can track, for instance, me from my birth until I die by this number. And all my diseases, you can look them up, all my operations, the complications, what I have been driven the social cost on, and what I have had for medicine and so on. You can combine all this information. And this is me, and I am 52 years old, born on the 10th of June, and this is my special number. So this is my ID number. Only me has this. And God forbid it, if I had a hernia, I was registered, and then I could be tracked in the National Patient Register throughout my life. If I would have an open abdomen, some kind of operation later on. And in same wise, I can be tracked if I have a twin. You can see, well, is there a connection with twins? If I have a breast cancer, I will not have that. We are our colorectal cancer. How are things combined? How is everything understood here? So we do have some good possibilities, I think, and I think they are requisites for doing a good registers. We discovered some years ago, or maybe it was a Danish problem, maybe you also have that problem in Ireland, but we had lousy results after ventral hernia repair, and that accounts for incisional as well as umbilical small hernias. Lousy results. 1 out of 250 patients died from laparoscopic or open elective surgery, and this is just moderate size. It's 5 centimeters or so, 5-8 centimeters. Major complications in 4-5%, 11% complication, long hospital stay, readmission, very much. And we had no whatsoever, maybe you have in Ireland, but we had no whatsoever consensus on how to treat this. We had high complications rates, as I told you, high recurrence rate, and the studies out there, they were very bad, sorry to say it, many of them. Not yours, otherwise, but many of these studies were very bad. So we started up in 2007, built on the model, built on what we have learned early on. And again, this was the model. It was all about meeting, discussing hypotheses, and they set up 2 hypotheses for this specific database, and that was to improve, unify, simplify surgical techniques. Very simple. And why? Well, to do results better for the patients. And you can talk about proms, you can talk about mortality or whatever. That's another discussion. But this was the overall hypothesis. And we do keep an annual report. It's just to give you an example. This is not research. This is just what the politicians want us to do. So we have a 30 days reoperation rate for recurrence. It should be below 5. Ours were 3 in 2014, and so on and so on. And it was okay. Length of stay was 0 days median, and it should be lower than 4 days, so it was okay. And now we introduced some month ago some new standards. We wanted that every surgeon, at least 40% of the open small umbilical hernias should be trainings. And all type of elective ventral hernia repairs should be used with a mesh. At least most of them should have a mesh, and the incisional elective lap and open should all have mesh due to the evidence from the literature. And now I should like to give you some example of so-called research, but this is not blood sample. This is just clinical research involving you and me as a patient. And over the years, this is just the Danish. I could take the Swedish too, hernia date, but I'm Dane, so I take the Danish. And over the years, we have now published 80 publications on this hernia thing. And this is really a stupid. It's just that we have different subjects that we have concentrated on. Emergency, pediatric, risk factors, recurrence in every aspect. So this is just primary outcome studies. And of course, most of these studies were on nationwide basis, covering 90% of the population, and many of them were controlled studies as well. And we took bias into consideration by multivariate analysis and stuff like that. And of course, it's not randomized, but within the collaboration, we also have done, and now it's 12, and we are continuing with 3 more randomized trials within this collaboration. So this is what you also can use this community for, doing the randomized trials. And this is one example of what you can find within the database. You can argue whether it's the truth, but one thing I tell you, this is a reoperation rate for recurrence over years. And you can see the reoperation rate is quite high. It's about 20%. A little higher for open than for laparoscopic, and it's 3 to 12 centimeter big defect, elective. And the funny thing is that there are quite a lot of randomized trials out there on this subject, and they are all severely underpowered. No one of these studies includes more than 300 patients. And if you should use this as a power calculation, you should use at least 1,400 patients. And I mean, you would never do that. It would never be done. And you would never follow patients in a randomized trial for so long. So this is the evidence that we have here. And one more thing, this is only the reoperation rate. But we know from a regional study in Denmark, and as you, Dwyer, mentioned, the reoperation, or was it you, David, the reoperation rate is not the same as the recurrence rate, not at all. Actually, we know that for ventral hernia surgery, it underestimates the true reoperation or the true recurrence rate by a factor 3 to 4, by a factor of 3. And we know because we have visited all these patients, thousands of patients in their own home, and CT scan and everything. My research nurse, she's very busy, so we know that. And why do people don't go to another operation? Well, it's quite simple. Many of these guys do not have any symptoms. They have their recurrence, but they live with it. But many of them have fear not to go under one more procedure. And a lot of the GP practitioners or the doctors recommend them do not do that anymore. Maybe that's a wise thing to do. Again, discussing within the community of the database, well, we had another subject we discussed. Where should we put the mesh in open procedure? It's always a matter of debate, no data on it. Should it be outside the muscles, under the muscles, inside the cavity, or whatever? And we had this including about thousands of patients. It was published 2 or 3 years ago. And it clearly demonstrated that the sublate position, at least after 42 months, was the best position regarding reaberration rate and also complications. But we have another paper now following these patients for 10 years, and it does not seems like it's the truth. It's not the whole truth, this one, but that would be another story. I'll tell you that later. Another thing, the smallest operation we do, but this is what people have, they come to the doctor with, is a small umbilical hernia. And there's a lot of small randomized trials, very small, and they all suggest that the suture do much worse than a mesh repair regarding recurrence. And so we looked in the database. Well, we found the same thing. We found that suture repair for very small umbilical hernias, 5,000 patients, they did much worse than mesh repair. But one thing again, is this the truth? No, I don't think so, because we do not know the true recurrence rate. This was not the clinical recurrence for these patients. And another thing is, we have indications that these patients, although it's just a tiny operation, we do have some studies, although retrospective, but it was with a prospective follow-up, good validated questionnaires and stuff like that, that suggesting that 5 to 10% actually have a severe problem intervening with their daily life after this small operation. So chronic pain and the true recurrence rate is not known. So that's why we went in again, discussed it within this community. What shouldn't we do a new study? And we did a new study with very small defects. So there's a lot of patients with this disease. And this time we visited all these patients. We saw them all. Not only we saw the reaberration, we saw them clinically. And after these 16 months, you had the sutured repair, which mostly were PDS sutured, with 21% recurrence and 10% after mesh. Even that is a lot. That's a lot, isn't it? And what the funny thing is, if you did a sub-analysis on the very small one just having 1 or 2 stitches, even that did much better if they had a mesh reinforcement. Even those very small ones, and also accounting for the little bigger ones. Chronic pain in a validated questionnaire to all these patients, severe chronic pain, making people stop working, 5%. Surgical site infection, 2%, and there were no difference between the surgical group, no difference. This finding from the database is replicated in a not yet published study from Holland in a Jiggles group. I talked to him 2 weeks ago. They sent it in now, but it basically showed completely the same thing as the database findings. Another thing that we went into in the database, because we have so many patients, we know exactly what goes on during the operation, was this fixation thing when you do the laparoscopic incisional hernia. Should it be absorbable tax or should it be non-absorbable tax? Non-absorbable or absorbable tax is supposed to give less pain, and it should be very good and cheap and everything is nice to work with. But again, we found that if we look on the reoperation rate and the clinical recurrence, all these patients were also visited in their home. The absorbable tax did much worse than the non-absorbable tax. But what about pain? Well, chronic pain, 15 versus 16% in each group, no difference. So maybe it's not the way to go with this tack fixation. We did another study, so we did a fibrous sealant versus Protax, and it was a small study, a randomized trial. And the sealing, fibrous sealing without closing the defect was, the early result were excellent. Almost no pain if you had the sealing versus the Protac. But we did this naughty thing. We followed up this patient 1 year after, and the result were lousy. Lousy. All the glue guys, they did poor. And the larger the defect, the worse. So that's not the way to go. Trocar Hernias is just an example of what you can use the database to combine it with the National Patient Registry. We tend to believe that it's not a problem with the Trocar Hernias, Trocar Hernias it's called, yeah. And we had almost 12,000 patients that we could follow for 14 years, and we knew that these patients only had one laparoscopic procedure. It was a clean procedure, could be lap cool, whatever. Only one. And what we basically found that the incidence of trocar hernia, operation for trocar hernia, was very, very low compared to laparotomy. We know that laparotomy hernia is up 20%, maybe even 30% if you're honest. So this is a nice result, actually. But what you should be aware of is that 16% of all these operations were actually emergency cases. So the message is here, at least what I think, if you discover a trocar hernia, I think you should offer this patient an operation. It's not the same as if you find an asymptomatic umbilical hernia. I think there is indication to offer an operation. It's a small thing, but I think you should do that. Emergency, what about emergency? Is it dangerous to be operated for a hernia in an emergency? The short answer is yes, it's very dangerous. The model is the same as we use every time. We go in the database, find the patients, and then we do the clinical follow-up. And here is the 5,000 to 7,000 patients, umbilical hernias. Well, the results after emergency is very, very, very much worse than the elective. It's not surprising, but it's surprising that the results are so bad. You can imagine an emergency umbilical hernia operation with a mortality comparable with emergency colectomy for IBD. So it's a bad situation. And the same numbers for incisional hernias, completely the same. What about peristomal hernias? Many of you know the literature on peristomal hernia repairs outcome studies. It's not very good. Studies are very small and not very well described. I don't want to offend anybody if they've done it, but they're very heterogeneous and not very well described. So we did a study within this database where we knew exactly every details on these patients. And we found that this was the biggest study ever. The biggest study until that was 79 patients, but this was 200 patients. A high readmission rate within 30 days, high reoperation day within 30 days, and a high mortality of 6% within 30 days. And if you had an emergency procedure, believe it, it's unbelievably dangerous. Unbelievably dangerous. Another subject which is quite interesting because it's never been described before, only in small 2 or 3 cases, is, well, what happens when we take a foreign body and put it inside the abdominal cavity or outside? You know, if you make a new headache pill, it costs you billions of dollars. But you can put everything you like. You don't even need a sheep, some kind of animal experimental study. They come to your office all the time. They come. Sorry if there's a company here, but you know, you don't have to prove anything. You could just put anything in it. So how does it go, these patients? And again, we're lucky. We have the information from the database. What went on the primary operation, and then we could follow these guys for years. And just an example, there was a 60-year-old lady coming to my office. She had an abdominal swelling and some pain, and well, I thought she may have a cancer, actually. She had an umbilical hernia repair some years ago, a recurrence, and then a new one, a Gore-Tex repair, laparoscopic, years ago, and she was okay, and I did this colonoscopy, and I thought that it didn't look like cancer. It looked like, to me, it looked like a tack and a mesh, and and this was the CT scan. You see the lumen here of the colon, and the mesh and the tacks. And this was the colectomy I did. And again, I guess you all have done this, but to me it was an eye-opener. What goes on here? What goes on? It's not that you shouldn't use the mesh. It's just that we need a quality monitoring long-term of what we put in. So this is not yet published, but we hope to have it published soon. This is a lap and open procedures with surgical interventional risk. Surgical, not medical intervention, but only surgical interventional risk. Reoperation, strangulation, removal of mesh, or whatever. And what is important is not that it lands on about 6% over from 6-8 years. No, the important thing is that the risk increases. So if we go out here in 15 years, what would it be like to have a mesh inside your body, outside or inside? What's the real risk? So, in conclusion, summing up, this database on a very small procedure, very common, it's been running, it's still running, provides some large-scale nationwide data, like many other databases. We try to quality monitoring, but that's not the fun part. The fun part is the discussion among the surgeons and how to go on to provide improved quality. It's important if you are interested in doing this database, and if you cannot do this, don't do it. Don't use all the time of this. Keep it very simple. Keep the variables very low. You have to have some kind of validation. You have to be able to track patients on a long-term follow-up. You have to have reliable IT systems, and you have to have all surgeons in your hands to do that. Otherwise, forget it. Then you do randomized trials, which is fun and good, but don't do this. It's all about discussion, communication, and it's also about, of course, making the randomized trials. Of course it is. It's not about doing that or that. It's a combination. And in this way, I think we can go forward to improve quality, maybe. Who knows? Thank you. Oh, sorry. This was the selfie, and this was me in the Royal College of Surgeons being a fellow. As a selfie, it didn't turn out too good, but.
Thank you very much, dear ladies and gentlemen. Thank you very much for this introduction, and it's a great honor for me to be here and to present some German thoughts. All these thoughts are not evidence-based because the evidence on education is very, very low. So I think I have, regarding this presentation, no conflicts of interest. And I want to focus on the outcome and hernia databases once again. Might be it's a bit boring. About education problems, teaching evidence, and teaching options. What do we have today? The outcome has been influenced by three different things: the surgeon, the biology, and the material. It includes techniques, mesh materials, fixation systems. Normally we speak about the hernia disorder, collagen disorder, and the biology has a big impact, of course. There are you can have an excellent surgeon, an excellent material. If you have a poor biology, you will get not even that good results as you would like to have. But I think the impact of the surgeon seems to be the biggest issue, and there is no doubt about this. George once has made a citation, for no other operation in general surgery, the impact of skill and experience is bigger. The outcome, I think, of course, if we think about outcome, we have different levels, and not everything is quite the same or equal. The rate of severe complications, it's of course a bigger impact on the outcome at the other versions like learning curve or costs. How do we can improve the outcome? The outcome can be improved, and congratulations to the Danish hernia database, because they have a long history, and of course they have shown the only existence of such a database will improve or increase the quality. Only the existence, there seems to be there is somebody behind you who is observing you during putting all the data in such a database. We have seen, of course, a lot of databases are quite existing right now. We have them also in Germany since 2009. Right now we have in Germany more than 300,000 patients included in this database. That's a huge number of data. And I think the European was known already, and the Danish and Swedish as well. The German hernia database is also an online project, and it is free of charge. There is an English version available. Of course, if there is somebody interested in, they can join, if you like it. What kind of education problems do we have in general for surgery? I think the education is something which is also dependent on the skills, and the skills must be trained. Finally, we have the situation in most of the hospitals that we have an economic pressure, and that's why there is not enough time to create such a mentorship or anything else like this. The beginner operations, because I think the hernia operations have in the last 30 years a huge development which is much more complex than 30 years ago. If we remember to 1980, the world of education was very simple. There are existing only 3 techniques that was easy to learn and might be, I think, much easier than today. 15 years later, we have, I think, implemented some endoscopic or minimal invasive techniques, and 2015 we are looking after such a top technique which is until that time not existing. This year I have the pleasure to be in Washington, invited for the American Hernia Society meeting, and Gianpiero Campanelli from Italy introduced the so-called top technique. Now the top is existing. It's a total open pre-pitotal technique, but I think, of course, it's very similar to tip and mop and all these other techniques. How you can learn all these techniques? Is it necessary, or do we need only one simple technique? I think we know hernia is not hernia. I think there seems to be some differences between the patients. And, oops, that was a bit too fast. Already Nihus recommend more than 20 years ago an individualization of the hernia repairs. That makes all the thing more complicated. The direct hernias have more recurrences than indirect hernias. And I think the tailored concept is worldwide widely accepted, but there is no consensus how to do it. And that's a big challenge for this time. I think such a hernia principle, which is simple, safe, fast, and efficient, standardized, and cheap, is not existing. we should keep a good balance in between a tailored concept and such a one-fits-all technique to make it not even too complicated. The major problems are the lack of standardization, the one-size-fits-all technical approach, and a missing or missed outcome measurement. That is a publication from the last year. And we have looked into our own country, how developed is our own education, the situation, and we made firstly a survey among the participants of the hernia conference, the hernia days, and I think if you look on the results, they are not even to be proud of it. I think most of the surgeons think that the education is not even enough. We have made it once again in collaboration with the Association of the Surgical Society in Germany, and there were 1,300 participants, and I think the results are even a bit better, but not even enough. So the problems, if you look on the education in hernia, is that we have a big diversity. There is no existing best technique. We have, up until now, high rates of recurrences, chronic pain, and finally complications. Standards and guidelines are mostly for the residents confusing. The abolition of training operations, the insufficient education programs, and normally an open and critical discussion is missed. What is about the evidence? The Oxford level is very, very low. I think we have the knowledge that the endoscopic repairs have even more serious complications in the learning curve, and the learning curve is longer than a Liechtenstein repair. I think that's level 2B, level 2C, that's it. And then we have a lot of, I think, publications, I would say, with level 3, level 4. The surgeon's satisfaction, that's an interesting fact, of course, seems to be increased in the endoscopic procedures, but much lower in the plug repair. But who is doing a plug today? I think there is a lot of possibilities, and to keep it simple is not everything. The 10-year audit of Liechtenstein repair has shown in the learning process, it's much more time-consuming, and the results are not even enough or good enough. So you have the double of the recurrences in the learning process. Once again, the surgeon has the biggest influence. The outcome in a residency or a training program has shown some publications, which is published this year for the endoscopic procedures, that you have, of course, an influence by the access, by the entry technique, or the type of the surgery as well. What kind of teaching options do we have today? Of course, what was, I think, best known and which was mostly used is such a mentoring concept. But the mentoring concept costs a lot of time, and normally, of course, it's not even independent. It's a bias on a teacher, and normally not comparable. You have a very individual training that's quite good for most of the surgeons, and of course, it's a very good option to add. What we do now is a conference, and of course, you get an influence on the new evidence, but normally, I think there is a far distance, like here, to the audience and to the trainees. And the third option could be a step-by-step training what we have done in Germany since 2011. It's a chance to make a standardization. It is evaluable and, of course, comparable. Some publications in the last couple of years focus on different possibilities of training, on simulation-based training and also hands-on training, anatomical training, and e-learning platforms. All these things are something which are something to add, but they couldn't do the work alone. So I think the residents like this, I think, different learning methodology. So I think you have a possibility to make the learning process a bit more attractive. In summary, I think they should implement a dynamic and flexible educational program. We have once again asked our German surgeons, do you like or do you appreciate such a systematic education instead of Congress lectures? And of course, most of them say, yes, we do. And the same for a step-by-step education program. You should do it with a systematic and, I think, ongoing process so that you can develop a hernia surgeon. Since 2011, and in my second talk, I will focus much more on this hernia compact and Hernienschule, so we call that the hernia school in Germany. We have these basic courses, and we have 1 day of anatomy, 1 day of hands-on surgical training in different hernia centers, and a 3rd day of theory and presentations. We range the participants or the trainees, and we ask them, how do you feel before and after? And so before the course, most of them have, I think, an average knowledge about the theory, and quite after, they feel it's much better. The same for the technical experience, because the course is very practical orientated, and they feel after such a course of 3 days much better than before. So that gives up the hope that you can improve it. Teaching next generations, I think the surgery in the digital age is something, of course, which is upcoming, and there is a publication. The residents prefer simulation training, web-based learning, hands-on laboratory, videos, networking with new media. That's something which is could be implemented. The tasks for the future are, of course, the education is needed to get better outcome. A step-by-step education seems to be a good possibility, with a possibility to compare and to standardize. You should include new learning methods with a good balance between different options, and you should sensibilize the surgeons for outcome and databases and attract more surgeons for the field of hernia surgery. If you ask me once again, of course, I say a big yes to this. And my final citation is from an American: education is learning what you even didn't know that you didn't know it. Thank you very much.
Shall I perhaps put a question to the panel and ask them, do you think hernia surgery in Great Britain and Ireland should be a speciality? And my colleagues from abroad would be interested to hear their thoughts.
It doesn't move. Well, hernia surgery includes a huge heterogeneity in different types of hernias. It depends whether you're talking about groin hernias, incisional hernias. I think there's an argument, certainly when you start looking at the more complex side of incisional hernias, and there's a number of grading systems out there. When you look at sort of type 3, type 4 and type 5 incisional hernias, that they should be going to people with a special interest. I think if you were to turn around and tell surgeons that they shouldn't be doing inguinal hernia repairs anymore, there wouldn't be a very receptive audience, and probably for good reason. But I do think it's important that we measure our outcomes, because only then that you actually can start to make those arguments, if you feel that that's the way to go. I mean, I don't personally feel that would be the way to go for groin hernia surgery, but certainly for multiply recurrent hernias, patients who have chronic pain, complex incisional hernias, then yes, there is a role for specialisation.
Paddy.
I mean, if Paul's data is correct, that you have such a high percentage of surgeons, 25% doing one hernia a year, and the real problem with that is that we don't really know what they're doing in private practice. But if in actual fact they were doing one hernia a year, then it would not be unreasonable to maybe ask the city not to do that. And to have surgeons to try and at least have a volume of 20 plus every year. For England, I think for our complex hernias, of course, I think we should have people, especially those.
Any comments from our European colleagues?
In Germany, I think we have the situation that we have some enthusiasts in doing hernia surgery, very common, but the hernia surgery is mostly a common procedure, which is done everywhere. And might be there is an ongoing discussion also in the German Hernia Society about how to divide the patients and to select patients which are a bit more complex into centers. They are, I think, advanced and have more experience in doing this. But I think that's a very critical and, of course, very controversial discussion ongoing right now.
Yeah.
We have, of course, the possibility of certificates, and there is existing a society in Germany which makes all these preparations for these certifications. And I don't know, is it the right way or not? I can't answer it.
Thank you, Ralph. I think we have a question.
I'm Ian Muir from the Priest of South West Scotland. This question is maybe for Thue Bisgaard. One of the parts of the system which no one has mentioned today is the selection of patients for operation. In the UK, for better or for worse, patients are seen by junior staff or by consultant staff in the inpatient department. And frequently the name goes, the usual process is the name goes on a waiting list. It's usually a pool waiting list. And then the surgeon who does the operations has never seen the patient before. Do you have any standardization or any comments to make about which patients should be selected for which should be
So,
the operation benefit?
the sound is not too, can you hear me? Okay, the sound is not too good, but as I hear you, you're asking about indication for doing elective surgery on these kind of procedures, right? And I am, like in the old time, for the watchful waiting studies for groin hernias. I'm preparing now 2 randomized trials on watchful waiting, one for the umbilical epigastrics and one for the uncomplicated incisional middle-sized hernias, because I have not the slightest clue, not the slightest idea if I am doing or my colleagues are doing these patients any good or we are not. There are 2 retrospective studies now out there indicating that there is quite a high crossover rate from those guys offering abdominal binders in the long run, so they got operation anyway. But patient-related outcomes, quality of life and stuff like that is not reported as primary outcome in any ventral hernia studies. So, of course, I have my personal idea in the office who I would like to offer operation, but I'm not sure I'm right, actually.
Thank you. Can I ask here, from the audience of surgeons, who collects their data? Please, show of hands, prospectively. So it's very few. Who would like a system in place where every operation they undertake, you can collect the data prospectively? Yes. And then final question is, who would like it to be mandatory? Yeah, so I think it's pretty unanimous there. You know, we need a registry, we need to collect this data, and it needs to be mandatory. And I think we all agree on that. Any more questions for our colleagues? Any more comments from our colleagues from any of the questions?
Can I just, in response to the asymptomatic or the minimally symptomatic hernia, but we have done a randomized trial, as you know, and the conversion rate is about 10% per year for inguinal hernia. But rather surprisingly, for umbilical and incisional hernia, the conversion rate is about 1 to 2% per year. So it's completely different.
Excellent. Well, I'd like to thank our speakers for keeping to time and giving very interesting talks, and I'd like to thank you for attending this session. Thank you very much.